Thanks, Candace. I appreciate that. Yeah, I have no disclosures here. Some of the designs that we'll talk about are designs that I've used, but I have no financial obligation to any one of these. And I've actually used 3 different types of systems for reverse shoulders and still do, depending on the case that we're doing. So in any case, to start out, so Candace, am I just telling you which slide or when to move to the next slide, that kind of thing?
Yeah, I will follow along as best I can.
Okay. All right, so let's go to the next one. So first of all, just a brief introduction on reverse total shoulder arthroplasty. It was developed back in the 1980s. The main reason was to treat rotator cuff arthropathy in the elderly mainly. There was initial great success where, if you look at prior studies, there's a 10-year survival rate on the Australian National Joint Registry because they kept great records in those in Australia. Anyway, 10-year survival rate was 94%. And so in Europe, it caught on pretty big. And in the United States, it took a while for us to get going on it because I think only in the last 10 to 20 years have we started to really use reverse total shoulder on a regular basis. But even back then, that led to expanded indications. So if you look at one study in 2009, the proportion of primary total shoulder arthroplasty cases that were actually reverse shoulders was 42%. Just 9 years later, the study was redone, or the survey was redone, and looked at, and 78% of primary total shoulder cases are reverse shoulders. And I can tell you in my practice, that's probably fairly close. I do most primary total shoulders as reverse shoulders, and we'll talk about some of the reasons for that. Okay, so next slide. So some of the original indications, like we talked about, were arthritis with rotator cuff tears or cuff tear arthropathy. And the reason for that is because if you do a anatomic total shoulder without a working rotator cuff, then you lose abduction and external rotation or actively. And so they start shrugging and they don't have good function of their shoulders. And so reverse shoulder design was to compensate for the lack of the rotator cuff function, and it worked very well. And so other indications early on were proximal humerus fractures and tumors. And then some of the expanded indications, because we saw such great success with reverse shoulders, was for posterior glenoid deficiency. So even if you have an intact rotator cuff, but you've got a large amount of deficiency on the posterior aspect of the glenoid, that's been shown to predispose patients to instability and in early glenoid wear and failures in anatomic shoulders. So reverse shoulders are for that. Massive cuff tears without arthritis. So if you don't have arthritis, but you don't have a rotator cuff, then one of the things to think about for patients in that scenario is a reverse shoulder, because once again, the deltoid muscle is then leveraged to allow for active abduction and forward flexion to compensate for the loss of the rotator cuff. And then, of course, revisions, and then more recently, younger patients. There are some studies that show that the survivorship in younger patients is equivalent to basically other joint replacements like hip and knees. And so, granted, younger patients still have higher revision rates over the long term and so forth, but originally it was thought that shoulders didn't last long at all, and so you don't want to put them in younger patients. But recent studies show that the survivorship is somewhat equivalent to total knees and total hips. So there's some expanded indications for that too, but that's still controversial and that's ongoing. So talking about posterior glenoid deficiency, mainly this is with the B2 glenoid or the type C glenoid. And what we see here is, if you see the picture on the bottom, the middle picture, there's that classic B2 deficiency, and then the type C dysplastic glenoid. And the reason for that, if you go to the next slide, in an anatomic total shoulder, this leads to posterior head subluxation. And that leads to glenoid wear and loosening. You get this rocking horse effect where the glenoid gets loose and has increased wear. And then you get particulates and things like that, and osteolysis. And anatomic shoulders, the longevity was decreased significantly. If you look at the studies that show anatomic shoulders done in these types of posterior glenoid wear or posterior glenoid deficiencies. So the nature of the rotator or the reverse shoulder is that it has a constraint design that corrects for that subluxation. And so the implants themselves are constrained somewhat to prevent the posterior subluxation. So yeah, going to the next slide. So the Grammont design was the original reverse shoulder, and it depended on medialization of the glenoid, which actually offers a lot of advantages to stability of the implants themselves. It was at a 155-degree neck shaft angle, and it was an inlay humerus component. And so just specifics of the design there. The problem with it is notching. So on the original design, there was one study or one series that showed up to 96% of some type of scapular notching with this original Grammont design. And actually in this particular picture, you can see the inlay humerus there as you have to ream out some of the metaphysis of the humeral bone. And then you place this humeral component into that metaphysis. So it's an inlay. And then the base plate has divergent screws. And then you have actually on this particular implant, you have the inferior cuff or eccentric glenoid where, you know, that little rounded edge on the bottom there is an attempt to prevent the scapular notching that's commonly seen with the Grammont design. So if you move on, so the medialization of the glenoid, it actually has some more pressure on the bone glenoid base plate interface, which leads to less wear. However, with the glenoid notching, you can get increased destabilization of the glenoid. So it's kind of a balance that, you know, you have to find there. Medialization also detensions the rotator cuff, and so that can lead to instability. You can get weakness in external rotation for the same reason. You have to repair the subscapularis on these because the implant will dislocate without that because of the imbalance of the rotator cuff. And so there's some of the considerations there. With a 155-degree neck shaft angle, this is due to notching. You get the micromotion of the base plate because you're losing some of that fixation on the inferior screws. That can lead to glenoid loosening and early failure of these particular reverse shoulders. So those are the design problems. So changes in the design, if you go to the next slide, the changes that are being made now to try to compensate for those problems are one, lateralization of the glenoid. And this can happen one of two ways. You can do it by implant design. And if you look at the picture A here, look at the glenoid base plate, you can see that there's an extension on the base plate, a little block there to lateralize it. And then on the, you can do it by a bone block or bone graft. And on the B picture, the picture on the right, you can see how it's lateralized based on a graft in that particular implant. So, and these two implants, I want you to note too, that these are onlay humeral stems and they're curved, which both lead to lateralization of the center of rotation based on the humeral component rather than the glenoid. So this one actually has both, both the lateralization of the glenoid and the humerus in these pictures. So look at the next slide. So the benefits of glenoid lateralization is that you do get decreased notching because the humeral stem is further away from the scapula. You get increases in external rotation because of the tensioning of the rotator cuff, but it can lead to increased loosening because now you're putting more stress across the base plate bone interface. Whereas medialization of the glenoid creates less stress across that base plate bone interface because it actually compresses it more. So you can get some glenoid loosening there if your fixation on the glenoid isn't optimal. So that's the glenoid. And then on the humerus, if you go to the next slide, humeral lateralization also maintains the glenoid stability because it keeps the medialization of the glenoid. And again, this picture is not a good one for that because it still shows that the glenoid is lateralized. But with humeral lateralization, you still have decreased notching, you still have the increased active external rotation, but you can have some higher dislocation rates. And you can have acromion fractures as well because you're actually increasing the tension across on the deltoid from the acromion to the humeral stem because you're lateralizing it that way. So some of the things that we try to do to decrease some of these problems, one is to decrease the neck shaft angle. So 155 degrees showed a lot of scapular notching. Later designs decreased that to 145, and now more recently 135 degrees. A lot of implants are doing this to show or to prevent the notching, which actually helps quite a bit. So if you look at the studies of the 135 degrees, you can see that there's reduced notching. There still maintains the increases in the active external rotation. You still have the stability that we're looking for with a reverse shoulder. With the humeral design, you can do onlay versus inlay designs. The onlay design does lateralize it further to try to prevent some of the fractures and instability that we see with that. There are some designs that mix it. So they do inlay designs to try to decrease that tensioning and still maintain the stability, but have a 135 neck shaft angle to reduce the notching and the problems that are associated with that. So a lot of this is still ongoing. A lot of the research is still being looked at and developed. Shorter curved stems on the humerus also allow for some lateralization of the humerus as well, particularly with onlay design. So medialization versus lateralization, still controversial, still under investigation. We're still trying to find the best way to do these. But those advances in the design have shown excellent decreases in wear patterns and stability and so forth. So those are the latest improvements in the design parts of it. So I did want to talk a little bit about acromion fractures. So the thought process behind this is that it could be due to increased tension on the deltoid. It could be these new prosthetic designs predispose patients to have these fractures. Base plate screw placement can also weaken the scapular spine and cause stress fractures there or large fractures there. And so as a way to try to treat these, we do the classification. So if you go to the next slide. So the Levy classification, has three types. Type 1 is along the anterior and middle deltoid origin, as you can see there. In the middle is the type 2 or zone 2, which involves the entire middle deltoid origin. And then type 3 is the entire middle and posterior origin. And so this classification is basically to direct treatment. So what do you do if you have a rotator or a reverse shoulder that develops an acromion fracture? And so if you go to the next slide, so here's the general recommendations. Type 1, generally we try to treat it in the sling. Studies show that sling mobilization has been fairly successful in helping patients heal these fractures, specifically if they're not displaced. And even if they are displaced in the type, in the zone 1, a lot of patients still do fairly well, even though sometimes their function may be decreased. Their pain is still better and they're still satisfied with them. However, it's still not an optimal thing to have this after your total shoulder replacement. So type 2, do you fix it? Do you not fix it? That's where it gets more controversial. There's one study that showed that they did non-operative treatment on all of them and showed that they did fairly well. There's another study that showed that half of them got fixed versus not. And so again, it's controversial. It's the best way. And all of these, the patient satisfaction scores went down compared to not having a fracture, as you might imagine. And then type 3, if it's along the spine, then the recommendation is to fix it. So there's a little meme from Saturday Night Live from a while back that I like. Anyway, so case example. So 68-year-old female, she had rotator cuff arthropathy. We did a reverse shoulder on her, and in this particular implant design, it's actually an inlay humeral stem, 135-degree angle. And so it's a kind of a mixture of the things that we just talked about. She fell. She actually had a trauma to her shoulder that caused her, which led to her fracture. So initially, 2 months post-op, she comes in with this acromion fracture. She was doing very well up to that point. And then she started having severe pain and after the fall. And then there's a CT scan of the same injury, which shows that it's probably type 1, type 2 area fracture as far as the location or the type of the fracture. And she had terrible pain. and wasn't doing well at all, couldn't do her physical therapy. So initially, if you go to the next slide, we treated her in a sling for a couple of months, and she presented just the other day with this new x-ray, which showed that there's some significant displacement of her acromion at the fracture site here. And so she's still not doing well, still wants to have something done about it. So the thought process early on was that she would do well with a sling. Now that she's not doing well in her sling and she's still not progressing after 2 months of conservative treatment, what do we do? So that's kind of my question to pose. The final slide there shows one of the proposed treatments is to plate these. Obviously, that's the best way to treat these if you're going to do something with it. And here's one particular construct that is a possible construct versus, this is a perpendicular plate construct versus locking plate on the top. There's different designs for these plate systems for this in particular. So in any case, 2 months after her fracture, we're looking at maybe plating this to see if we can get her somewhat better. So that's a quick rundown on the implant designs, improvements, and changes that we're making to try to make reverse total shoulders last longer and have better function. And then with acromion fractures, this is kind of my dilemma right now, is what I'm trying to figure out what to do with this particular case. So any questions on any of that?
And this is Bill Paterson. Great presentation. Thank you very much. Really nice review of the entire history of reverse, which is, I think, a very interesting history. So yeah, I mean, if we're going to kind of talk about this particular patient, that's a really tough one. That's going to be a tough fix. I guess one of my concerns with that particular construct is you're probably going to have to take down a fair amount of the deltoid. But there's probably not a much better construct that you could use, except I think there are some companies that make plates specifically for this. So you might be able to get more screws in the acromion with a single superior plate. But then that bone's going to be really bad. So I would definitely have a bone graft, like a structural fibula or something along those lines available. To try to do some sort of sandwich construct. I've never personally done that, but I've seen people describe that more for the scapula spine fractures, because as you mentioned in your presentation, those are more frequently recommended to be fixed surgically. But, as you said, with this particular patient, she's not doing well. So obviously her choice is essentially surgery or live with it the way it is. So that's going to be a tough one.
Yeah. So I was looking at this perpendicular plate construct. That's kind of a backup plan. There is a plate that I was looking at that's more like a distal clavicle plate that has a lot of locking screws that diverge and variable angles and things like that. That might be just as well or just as good of a fixation rather than doing, taking down the deltoid like you're talking about to try to fit this plate on.
I think the problem is if you just put a plate on top, I mean, there's going to be so much tension. So and again, I mean, I don't like technically, how are you going to sandwich it? Like that's difficult. But I would try to, have some, like maybe put the bone graft under the acromion to have something to get the screws in, right now I'm just thinking off the top of my head without having much evidence behind what I'm saying. So
yeah, I hadn't thought about the bone graft. That's actually something to consider.
I would definitely have a graft, because those, that acromion bone and the fracture site, there's probably some resorption there. That bone is going to be not good quality at all. I mean, this is the type of thing, like if you're interested, we could potentially do it together. Like if you have any interest in that, I'd be happy to,
Absolutely.
If you're interested. So
for sure.
Ben, it's Sheldon. Great talk. I agree with Bill's comments. So I've fixed one of these in practice. That's my N of 1, and I've always been resistant to fix these. And I'll tell you, my experience was not good. Same situation as this, reverse patient, spine fracture, just like this, not doing well. And so she twisted my arm, and I complied and fixed her, and she got infected, and it ended up ripping everything out, and she ended up with what she had, and she did fine, quote unquote, fine after that with what she had with 2 surgeries later. So that's always been the concern, is infection in this area. So I would just caution you to really counsel her very well that there's a high risk of complications, both with regard to infection and failure of the construct. Based on what Bill's saying, the forces on this are unbelievable. And in that particular situation, I think I used an Acumed plate. They have a plate that curves up around the acromion, so you get more screws into the acromion, you get a longer lever arm on your plate. And then, backing this up with your second plate here posteriorly adds, more fixation. So in that case, it was actually good fixation. It was rock solid. I was very pleased at the time of surgery with the fixation. So it didn't fail for that reason. But, certainly having a fibular strut graft like Bill's talking about is not unreasonable. You might be able to put that posteriorly there under that second straight plate, contour the ends of it a little bit down, have a burr ready. Might have to bend that plate a little bit, and you can wrap the plate right over top, line the plate over top of the graft across your fracture site just for more fixation if you need it. But try the Acumed plate, but it definitely counsel this patient that there's high risk for this to not go well.
Yeah, I would definitely agree with that for sure.
Yeah, we've had long conversations over the last, couple of months about this. And at this point, she's willing to try anything because she's not doing well. So hopefully we can get her fixed up here.
So then I guess while we're still at it, you said you use 3 different companies. I guess my question would be, why do you choose different companies for different patients? Like, what's your kind of indications there?
Yeah, so a lot of it was just design, comfort of what I was, how to put the implants in and instrumentation and things like that. In terms of the design aspects of it, I did do an onlay humerus for a long time. I've kind of switched to an inlay one for the most part because I don't like the tensioning of that of the deltoid that the onlay gives a lot of times. And so I've tried the inlay designs to try to decrease some of that. I've had some patients who start out with a lot of stiffness. And so trying to maintain some medialization of the base plate, but still having the 135-degree angle, I think has been helpful in lessening the notching versus still having better range of motion and decreased tensioning on the deltoid and the acromion there. So individually too, some patients are smaller than others, having a long stem versus a short stem, and those things are things that I consider from that standpoint.
Okay. Yeah, I've gone through that same, what sounds like kind of variability philosophy. When I came out, I was essentially doing a Grammont style, and now I'm doing more lateralization on the glenoid, and it's a not exactly inlay, but it's a thin on, like essentially just the poly is the onlay on the humerus, so there's not as much lateralization as it's interesting that one of the x-rays that you showed, or no, it's the graphic, the cartoon graphic of those plates shows a onlay humerus. I mean, that's the construct I was doing for a while, and I felt like I did have a lot more acromion fractures, which is what made me switch to an inlay humerus and some lateralization on the glenoid, and less distalization of the glenoid. So now for me, the sphere ends up pretty much at the bottom of the glenoid instead of, inferior overhang. So anyway, I've gone through a lot of that same thought process.
Yeah, there's one of the implant companies that I used. It was based on inferior, putting the glenoid more inferior to prevent the notching and that kind of thing. But was a onlay humerus, and so again, like you said, it put a lot of tension on the deltoid. I didn't like some of the outcomes from that, and so changing my thought process on using a different design. More inlay on the humerus versus less inferior, placing the base plate more along the bottom of the glenoid versus overhanging it. I think I like that better too. So yeah, similar thought process there.
Dr. MacQueen, we do have a question coming from the chat. What is your postoperative protocol for rehab activity modifications and weight-bearing progression for reverse TSAs?
Okay, so great question. Again, with some of these designs, the early Grammont design, the recommendation is to fix the subscap. And I've seen I've had a lot of patients who've lost external rotation, lost range of motion. They've tightened up because of, fixing these subscapularis tendons. But you have to do that with the Grammont design to maintain the stability. At least that's the recommendation. And some of these other designs, if you lateralize the joint, then repairing the subscap becomes problematic in some patients because it tensions the subscap, and so there's not enough length on the subscap to get the normal external rotation that you want out of it. But if you don't fix it, then you lose some of that internal rotation strength. And so lately I've kind of just stopped fixing the subscapularis muscle, and so that gives two advantages. One, you don't have to wait for the subscap to heal before you can be more aggressive on your range of motion in terms of external rotation. Early on, my protocol is that we do supine passive range of motion, basically to 20 to 30 degrees of external rotation, if that's what we see intraoperatively that they're able to do without, instability or over tensioning the repair if we do repair the subscap. And then over the course of the first 6 weeks, they're able to do activities of daily living. They can start weight bearing on it within the first month or after the first month. Because I've seen that the implants that I'm using are very stable. I don't have to worry about instability, whether I fix the subscap or not. But that's my thought process behind it. At the 6 week mark, they can do weight bearing on their walkers, and they can start doing more strenuous rehab, weight bearing activities and weightlifting. Bill, what do you think on what's your protocol?
So I repair the subscap as much as I can. I still think it's the right thing to do, but I do a semi kind of half-ass subscap repair. So it's a lot less strong of a construct for a reverse for me compared to an anatomic total shoulder. I put a bunch more stitches in it for an anatomic total shoulder. So I fixed the subscap, but I do not worry about it. I don't attempt to protect it at all in a reverse. So if it's my standard primary reverse is a sling for a month. For patients who need weight bearing, I say 50% weight bearing through the elbow, day one. But I don't want them using their hand to like push themselves up out of a bed or chair. So again, that's why I say through the elbow. Which I think makes it a little bit less onerous on someone who has to use a walker. So they might use a platform on their walker or something along those lines. And then I have them start physical therapy on the shoulder, so they can do hand, wrist, elbow range of motion day one. Shoulder therapy starts at 3 weeks. And initially to 90 elevation, 20 or 30 external rotation, but at 4 weeks, they can typically kind of progress to tolerance. I've heard Tokish, for example, does a, I don't know what he does. I think it's Arthrex, but he puts in a lateralized glenoid inlay humerus 135 construct. And he says he has his patients wear a sling for 1 day and then do what you want. So that whole rehab, there's obviously a large variety of thought processes and rehab protocols. But for me, it's still a sling for 4 weeks. So no active shoulder range of motion for 4 weeks. And then after that, just kind of slow progression, strengthening at 8 weeks usually. So that's my general protocol. If it's, I do a lot of the bone graft on the glenoid. So for me, that's a sling for 6 weeks just to protect it a little bit longer to make sure that graft heals. Although my current thought is I probably don't need to be that conservative, because that fixation, you know, with these newer implants and stuff is extremely strong from day one. So I'm considering backing off and making my post-op protocol less conservative.
Yeah, my post-op protocol is more in the line of what you described with Tokish. I've seen these patients do very, very well with being a little lax on the restrictions. And so I've had very few instability problems with these, and the loosening problems I haven't seen with these newer implants with the lateralization. So yeah, that's just my thought process there. I'm still, you know, day one, that's a little aggressive. I'm still not there yet.
That's what I was thinking.
Yeah, but I let them do a lot of you know, brush their teeth, shave, things like that. And if the women do their hair, if they can get up that high. I'm not overly cautious about that.
Thank you. I appreciate that discussion.
Absolutely.
So in sake of time, you want to go through, we have a couple additional case reviews by Dr. Paterson.
Yeah, perfect. And then we can do any other questions at the end. So I just have a couple of revision cases. First one is a 71-year-old male. He had a left reverse shoulder placement by outside physician in 2017, and then 1 week later had what was described as a hematoma evacuation. Then after that, he had a dislocation and a revision a month later. So he had 3 surgeries within a month. In 2017, then he was doing okay, but started having instability in 2020. 2021, June, he had a dislocation, which required him to go to the ER, and then had to have the reduction under anesthesia. So the first day that we saw him in clinic was June 24th, 2021. 5 days after that dislocation, no pain. This is passive range of motion, but he had pretty decent active range of motion as well at that time, just 5 days out from that dislocation. So you can go to the next slide. So these are the x-rays from that, you know, June 19th ER visit. So you can see, obviously the prosthesis is dislocated. So sometimes people say it's dislocated, but it's really not, but this is one of those cases where it was. So you can go to the next one. The ER post-reduction, still dislocated. So next. So obviously these are the fluoro views. So the doctor took him back to the OR under general anesthesia, was able to reduce it. So then next. So these are the x-rays when he came back to our office. So again, he's got really no pain, reasonable function, good looking x-rays to my interpretation. So then my thought is, well, I mean, that sucks. You had instability, but now it's reduced and you're feeling pretty good. So we went ahead and got the CT arthrogram and aspiration, which is my workup, my go-to workup for any sort of complex or painful or complication related to an arthroplasty. I pretty much always get an aspiration to work up infection. So that was negative, and he remained stable. So basically the conversation was, we'll see how it goes. And, you know, we sent him on his way and, you know, hope that he would never come back. But he did, unstable again. So I did not repeat the infection workup, but we got a new CAT scan. So I think that's the next image. So to me, looking at this CAT scan, and obviously I don't have the entire CAT scan here for you guys, but the components appeared to be well fixed, and they appeared to be in a good position. Obviously there's some osteolysis under the glenosphere base plate, but it did appear to be well fixed, and the humerus with that graded tuberosity resorption appeared to be well fixed. Obviously it's unstable. There's probably something wrong with the poly. So at this point, we proceeded with surgery because of his, you know, persistent instability issues. So you can go. So this guy, this is just kind of a slide on instability risk factors, and it's probably not fully inclusive. There's probably things I'm missing. I know one of the things in terms of the prosthetic factors I forgot to put under there is sometimes the components are not put in the correct position. So if the sphere is, you know, angled incorrectly, or the humeral version is bad, you know, that can increase the risk of instability. It's pretty rare for me to see, for example, like Ben was mentioning, if the subscapularis has failed in a reverse shoulder placement, it's very rare that that's the only factor that's contributing to instability. I think primarily because it's rare that we're doing that classic Ramont medialized design at this point. So just to run down, you know, from the top, the deltoid can be a risk factor for instability if there's a problem. So if there's a severe deltoid injury or axillary nerve injury, the only surgical solution for that is a pedicled pec major transfer, which I've never done, but it has been described. If it's a small tear or dehiscence that's usually related to a previous surgical approach, you can typically repair those. If there's detensioning of the deltoid because of the displaced mesoacromion, you know, pre-existing prior to surgery, or an acromion or scapula spine fracture, again, obviously, like we just talked about, that can be fixed, or you can potentially, if you have to do a surgery, you can potentially put more tension on, you can lengthen the humerus or distalize the glenosphere, so you can put more tension on the deltoid in using the prosthesis. And then I think sometimes instability occurs early on if there's a large hematoma. I think that creates some degree of atony or detensioning of the deltoid, and that can be an instability risk as well. And then again, prosthetic factors, if the combined distalization and lateralization of the humerus and glenoid is too little, that can lead to instability, as Ben was saying. I think people talk about the deltoid wrap effect, which is the graded tuberosity. When it's present, the deltoid muscle has to wrap around the graded tuberosity, which gives the deltoid a little bit more of a kind of stability creating vector. So if the graded tuberosity is gone, the deltoid is pulling more superiorly on the humerus, and with the arm in adduction, that particular situation can contribute to instability. So I think the deltoid wrap is a real thing. And then less commonly, heterotopic bone formation could create kind of a lever, depending on where it is. The humerus could lever out of the joint if there's heterotopic bone that gets in the way, essentially. So just because instability is probably the most common, other than infection, instability is the most common reason that I would have to do a revision. So these are basic rundown of those risk factors. So we'll keep going. So again, I did do surgery on this patient, mostly because of what we already talked about with the difficulty and complications related to fixing the scapula and acromion. I did not even attempt to fix the scapula and acromion. He was not having pain in that location. So again, his displaced scapula spine fracture or acromion fracture was probably at least contributing to his instability problem, but he wasn't having pain there. So I felt like it was not necessarily the right idea to attempt to fix that, given the complications associated with that. This patient already had the largest glenosphere. So basically I just switched it out to a new one, because at the time of his revision surgery, the polyethylene component of the humerus was completely dissociated. So the metal humeral tray was rubbing on the glenosphere, so it was very scratched up. So I basically took the sphere off, put on a new one, and then gave him more lateralization and distalization on the humerus by building up the tray and the polyethylene. So what I'm trying to show on these pre-op and post-op x-rays is that he's got probably about 1 centimeter more lateralization and about 1 centimeter more distalization, because the humeral and glenoid components were well fixed, and I felt like they were in a good position. So to take those out and revise them, I felt would just potentially create more of a problem, despite the fact that he does have some of that bone loss underneath the glenoid base plates. It was very well fixed. And then again, with the deltoid wrap issue, I elected not to treat that specifically. This would have been his, I think, 4th or 5th surgery. And I felt like putting a graft, so you can put a structural, tibia or femur graft laterally to recreate the graded tuberosity. I felt like that would have been risky, potentially for infection in this particular patient. So this is what we did. And at 3 months, he's doing pretty good. So hopefully that sticks for him. So I guess I don't know what's happening.
I do have a couple questions from the chat for both of you. Is there 1 to 2 things that you notice that predisposes your patients to dislocations early on, specific activities specifically to avoid, returning to ADLs too soon, etc.?
So just real quick for me, in a primary reverse setting, instability is extremely rare, thankfully. Again, I think the way that we're doing it now contributes to a lot of stability and improves that compared to the past. So for my own situation, instability for me is much more frequent when I'm doing a revision. And there's a whole host of issues that contribute to that. I think it's actually quite rare that it's the patient doing something they shouldn't that creates the instability. I mean, I've had maybe a couple of people here and there where they're like trying to pick up a really heavy case of water from Costco, instead of unloading it, and they're trying to pick up 40 pounds worth of water. Like if they're doing something really heavy and it kind of creates a kind of lengthening of the humerus, or if there's something that pulls on the arm quickly, something unexpected, those are rare instances, but I'm just thinking of one particular person that occurred. So I don't know, does that answer that question?
I would say the same thing. A quick traction on the arm is where I've seen dislocations happen with the reverse. Like one particular lady had this very old vacuum cleaner that must have been hugely heavy. And as she was throwing it forward to vacuum her carpet, her shoulder dislocated as it pulled her arm out. So just things like that. I think having traction on the shoulder early on, like a quick traction, is where I've seen these dislocate in the primary setting. So
yeah, and it usually is a pretty unusual event. Again, like the water example and the heavy vacuum. I mean, those aren't ADLs exactly. you know, it's something relatively unusual and pretty forceful.
From our inpatient rehab, if inpatient and the patient has orders, interested in range of motion as it relates to the patient's ability to complete basic self-care tasks.
So
yeah, if the question is, can they do self-care tasks from a reverse total shoulder standpoint? And my recommendation is that they can brush their teeth, they can wash their face, they can do things like that. That's, you know, and they can do that early on within, you know, after the first week.
How about wipe their butt?
No, definitely not.
Yeah, no, I tell them not to. And if they absolutely have to with that arm, I tell them to go from the front or get a bidet or something along those lines. So what I tell people is, you know, day one after surgery in the sling, you can move your hand and wrist and elbow. So you can bend your elbow to get to your face. So theoretically, you can brush your teeth. You can, if you're bending your elbow, you can reach your face to wash it or eat or something along those lines. But I still kind of like basically assume they're doing it or tell them to do it in the sling. And again, I mean, like we talked about, like my thought process is changing on that. So I think if we come together with rehab protocols, we'll probably be able to be less conservative than that. It's what I just said.
Yeah, I agree. I mean, early on, I was very conservative. They had to be in their sling, all of that stuff. And I agree. If they're, you know, I tell them to unhook the sling, but still have that the abduction pillow there to rest their elbow on. And that kind of dictates, you know, limiting their external rotation and preventing them from doing the internal rotation, like reaching behind their back or wiping their backside from the back, because I think that's a little too much range of motion that early on. So, yeah.
Plus, people will force it, you know, like I wouldn't think,
exactly.
You know, there's like a goal there, you know, they're going to keep going until they get there. So that's where I would, you know, it's different if you're just reaching your elbow to your face to like wash your face. If it starts to kind of hurt, you're going to stop and you're going to use your other hand. So yeah, the kind of butt wiping thing is not something we talk about with every single patient, but you know, we tell them not to be reaching around to be doing that during the sling time.
Hey, this is Jarbo. Great talk, guys. I would say for the therapist, and I try and tell every one of my patients, just because my grandma had a reverse, I tell them practice brushing their teeth with their other hand just in case. And I always tell them to make sure they can wipe their butt with their other side because we don't tend to talk about it that much. I try and bring it up every time because I've had a few, not dislocated, but have issues or get upset because that was never told to them. So just a little thing, but the therapist can even put that into their little speech.
No, and those little things are big to some individual patients for sure. So that's good. You know, pre-surgical communication, absolutely.
Thank you, gentlemen. We are at time if there's no additional questions.
Thanks, guys. Really appreciate the attendance and great questions.
Yeah, thank you very much. Appreciate it.
Good job, Ed.
Thank you.
Thank you, everyone. Y'all have a great day.